executives. Well, most of the executives are not here, but I can see in absentia, I would like to acknowledge the chairman, national chairman of CPAN, with the person of Dr. Joseph Nadu. Then I can also see Dr. Timipri Okeogene, the chairman for the Education and Training Committee, and every other of the executive that's available. We also want to acknowledge the presence of the states that are the states presenting today, presence of all pharmacists, clinical pharmacists from Cross River State. We acknowledge your presence and every one of you that have taken out time to join us today. My name is Pharmacist Good News Agare, and I'll be your moderator for today. Okay, even as we continue, now for us to have a seamless presentation, of course, every person has been placed on mute except the moderator and some few persons. Now the presentation is going to max the whole presentation, including questions and answer. Question and answer section max will be 10:30. We're not going to exceed 10:30, so it could be less than that. Time for the presentation will last for the presentation by speaker for today. It's going to last for 30 to 45 minutes. So we have 35 minutes, 30 to 35 minutes. That's 35 minutes max. Then thereafter, we'll take questions and comments. Now, even as the presentation is going on, questions can be dropped on the message box. Questions can be dropped. Then after the presentation, you can, if you have questions to ask, you can identify by raising up your hands through the icon there. You can then you'll be called upon to ask your questions or comments. Now, today clinical presentation will be made by Dr. Chikezie Okwesi. Please, pardon. Okay, Dr. Chikezie Okwesileze. Okay, and this presentation is made on behalf of Cross River State. Now, a brief profile about our presenter, Dr. Chikezie Okwesileze. A brief profile. Dr. Chikezie is an assistant director and head of pharmacy research and training, University of Calabar Teaching Hospital, which is in Cross River State, and is also a lecturer at the Faculty of Pharmacy, University of Calabar. He's a recipient of the Distinguished Service Award of the Association of Hospital and Administrative Pharmacy of Nigeria, APN. He has held several positions in IAPN and PSN, Cross River State. Dr. Chikezie is a graduate. Okay, Dr. Chikezie bagged his B.Pharm degree from the University of Uyo, Akwa Ibom State, went further to obtain his MSc in pharmacology from the University of Calabar and a PhD in therapeutics from same University of Calabar. Also to add, he also bagged his Doctor of Pharmacy degree from the University of Benin. Dr. Chikezie has spent 16 years experience as a hospital pharmacist. He started at inpatient pharmacy, where with time he became the team lead for ward rounds in pediatrics and surgical ward. He later became the unit head and coordinated all ward rounds in the inpatient pharmacy. Due to his wealth of experience in research, he later became the unit head and coordinated all ward rounds in the inpatient. Okay, then he was appointed to head the UCTH Pharmacy Research and Training Unit activity. And some of the activities that go on there is pharmaceutical research, clinical meeting, training of students, intern, and other staff, quality, drug control, drug compounding and constitution, manufacturing of pharmaceutical products like methylated spirits, bleach, antiseptic, disinfectant, and the likes. He has made several scientific presentations locally and has several publications in journals, with core values of sincerity and hard work, as well as vast experience in pharmacy, in hospital pharmacy. He aims to passionately work assiduously to leave footprint of pharmaceutical best practices, which will serve as a guide to the coming presentation. To interest you to know that our able presenter, Dr. Chikeze, is also married to a pharmacist, Ijoma Okoesileze, and they are blessed with children. The topic of the presentation, of our today's presentation, is medicinal drug compounding as a strategic component of pharmaceutical care. Let's make welcome our presenter, Dr. Chikeze Okoesileze. Thank you very much. Okay, so over to you now, Dr. Chikeze. Hello, can you hear me? Hello.
Yes, he's hearing you. Maybe he has a problem with network.
Okay.
Yeah.
Okay. Let's exercise a little patience. I guess our presenter for today having some little challenge with his network, having some challenges with his network. I guess he will join us soon again. Okay, while we wait for our presenter, we want to acknowledge everyone available. In essential, our national chairman is not here yet, but we acknowledge everyone that's taking out time to come to join today's presentation, and also our national executive of Clinical Pharmacy Association of Nigeria. Is we're waiting for our presenter. Let's exercise a little patience. He will join us soon. Guest network just our topic for today is medicinal drug compounding as a strategic component of pharmaceutical care. Our presenter is Dr. Chikeze N. Okoesileze. We're waiting for him to join us. He was with us before. It's network challenges. He will join us soon.
Maybe Pharmacist Ijoma can help us call in to find out what is really going on.
Okay.
Ijoma.
Yes, I was about sending a message. So, Pharmacist Ijoma, Okay, while we wait for our presenter, we also want to acknowledge the presence of Professor Cyril Osifo, Professor of Pharmaceutical Chemistry, University of Benin. Sir, you are highly welcome. Also sorry for the delay. Network sometimes can be so unpredictable and
Hello, good evening.
good evening,
Yeah,
Dr. Timothy. You're welcome.
we doing? Good to have you. So what's happening? The presenter, is he having network?
Yes, he was online already projecting, about to start before
Yes.
network.
To share his slides. He was trying to share his slide and suddenly he disappeared.
Yes.
Wow. So have we called him? What's happening? Can we? I don't know. So are we waiting? Let's waiting for a while to see.
Yes, we're trying to get across to him. Just like I call him now, I may even be logged out
Yes,
because
it's true. It's
the
true.
same.
Okay. Wow.
Okay. Yeah. Hello, sir. I don't know if you can get across. Okay, if you can get across to him, he was about sharing the slide before the. Oh yeah, can you call him? Okay, call him. Or send me his number then. Let me know what's up. Hmm. A little more patience with us. Okay. Can you hear me? Hello? Hello, can you hear me? Okay, please,
Is it
let's,
back?
yeah, I just spoke with him now.
Okay.
In the next 60 seconds, he will join us, please.
Oh, no problem.
Yes.
Okay.
In the next 60 seconds. He's having network challenge, so he's trying to change to another network. So sorry for that.
Wow.
Okay, so we are all welcome once again. I can see our national chairman, Dr. Joseph Madu. He has joined. You're welcome, sir.
Good evening and thank you everyone. God bless us all.
Good evening, sir.
You're welcome, sir.
Thank you. Chairman, Education Committee.
Thank you, sir.
Yes.
He's joining us soonest. Okay, I think he's almost there now. Okay. So okay. Francis Bello, you can. Okay,
Yes, you can go ahead and unmute yourself. Yes.
Okay, Dr. Chikeze, you can unmute yourself now. Why you share your slide? Okay, so let's make welcome Dr. Chikeze once more as he starts his presentation.
Thank you very much, Dr. Goodness Zagari. Sorry for that technical hitch. I believe that you can hear me very clearly now.
Yes, sir, we can hear you.
Okay, please, can you see my slides?
No.
Not yet. Not yet.
Not yet. Okay. Okay. Just a minute. Let me upload the slides for you to. Sorry about that. Thank you very much. I believe that the slides can be seen now.
Yes, yes, sir. You can go ahead.
Yes.
Okay, thank you very much. I want to apologize for the slight hitches we just encountered. It was from network. MTN was not supportive enough. I had to switch over to another network. Thank you very much. I want to thank the National EXCO of CPAN and the members of the Education and Training Committee, and in fact, all members of CPAN for the wonderful job we are doing. I want to congratulate us because we are doing very well at the moment. Like Dr. Agare has already said, the topic we are discussing today is medicinal drug compounding as a strategic component of pharmaceutical care. By way of trying to outline what we're going to discuss today, we're going to look at compounding, look at pharmaceutical care, the philosophy of pharmaceutical care, compounding as a strategic component of PC, benefits of compounding, common equipment needed for compounding, then summary and conclusion. Now let's look at what compounding is all about. Compounding is the art and science of creating or preparing personalized medications for patients. Individual ingredients are combined in the exact strength and dosage form required by the patient. The pharmacist preparing the compound work with the patient and prescriber to meet the patient's specific needs. Now let's look at pharmaceutical care. Of course, like we know already, pharmaceutical care is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improves a patient's quality of life, as defined by Hepler and Strand in 1990. In this model of practice, the pharmacist takes responsibility for a patient's drug needs and is held accountable for meeting these needs. Now, the Pharmaceutical Care Network in Europe in 2013 defined pharmaceutical care as the pharmacist's contribution to the care of individual patients in order to optimize medicine's use and improve health outcomes. Now, whichever definition you take, the meat is the same. Pharmaceutical care involves two major functions: identifying potential and manifest problems in pharmacotherapy, that is drug-related problems, and then solving the problems and preventing the potential problems from becoming real for the patient and his therapeutic outcomes. Now let's look at the philosophy of pharmaceutical care. It has four basic components: social need, caring, patient-centered care, and pharmacist responsibility. When you look at patient-centered care, it means the pharmacist identify the individual drug needs of a particular patient and tries to meet it. And pharmacist responsibility is basically meeting drug-related needs of an individual patient. So the professional responsibility of a pharmacist clinician, defined by the philosophy of pharmaceutical care, are to identify drug therapy problems, resolve them, and importantly, prevent them from occurring at all in patients. This requires that the clinician comprehensively assess a patient's drug-related needs, develop a care plan that address these needs, and follow up to determine that the desired outcomes are achieved with no harm done. In some categories of patients, for instance, the pediatric patients, oncology patients, geriatrics, patients with organ failure, etc., the drug needs of the patient cannot be met using the commercially available products. Most times, the problems will range from unavailability of right dosage form. For instance, a pediatric patient, a neonate, 1-month-old child, being prescribed captopril, ciprofloxacin, nifedipine. You see, there's no dosage form, there's no suspension, there's no syrup of this drug available. Inability to accurately administer the desired dosages. For instance, an adult who can swallow tablets, prescribed 1 milligrams of Altein. You see, the best you can get is 5 milligram tablet. The patient can swallow tablet quite all right, but you cannot administer 1 milligram from that 5 milligram tablet. So something has to be done to meet this patient's need, and the compounding is the only way that can be done. Unavailability of products with desired drug combinations or the strength of the components. For instance, a patient may be having dermatological problems, needs like 30% salicylic acid, but what you can get in the market is 3%. Sometimes the patient may need 6%. There's no way you can get this strength in the market. Compounding is the only way out that the clinician can meet this patient's drug-related need. It is therefore through compounding that the clinician can formulate a medicinal product with a precise strength, appropriate dosage form, devoid of incompatible excipients and additives that can meet the specific needs of the patient while ensuring no harm is done. Now, structure criteria for pharmaceutical care. For any center to be able to render comprehensive and effective pharmaceutical care, there must be availability of licensed and experienced clinical pharmacists. There must be availability of reference materials. There must be a designated area for compounding. There must be private counseling area. Record-keeping capabilities must be visible. Pharmaceutical care documentation forms must also be there, etc. With all this, you are set to render comprehensive and effective pharmaceutical care. Now, let's look at benefits of compounding. With compounding, you have the flexibility and ability to alter dosage forms, to alter strengths, to avoid dyes, additives, fillers, preservatives, or sugars, ability to alter taste, ability to create medicine that is not commercially available. These are the leverages you have when you have an effective and well-equipped compounding room in your facility. So in essence, compounding creates custom solutions for specific problems. All right. In University of Calabar Teaching Hospital, we do compounding. We compound a lot of medications. We compound oral liquid solutions and the topical ointments. Oral capsules, suppositories, topical spray, topical powders are possibilities, although those ones are work in progress as we're trying to put together facilities that can enable us to do all those other compounding. Now, looking at the list of medications that you need to compound, let's take, for instance, about 15 of them and look at number one, quinine. We all know that quinine comes in 300 milligrams tablets that is coated. Most of the times you see pediatric patients coming with prescription of 90 milligrams, 170 milligrams, 210 milligrams. There's no way you can use tablet cutter to divide this quinine tablet to be able to get 90 milligrams. It's impossible. So the only way out is to reconstitute the tablet into oral suspension using the appropriate vehicle and using the appropriate containers for packing. We use vitamin C, we use simple syrup, depending. So that's what we must do to be able to meet the drug needs of pediatric patients that require the use of quinine. Captopril is one of the drugs mostly prescribed for pediatric patients with cardiac problems. You see a baby of 2 days with ventral septal defect using captopril, 5 milligrams, and we know that one tablet of captopril comes in 25 milligrams. There's no way you can administer 5 milligrams of captopril to a 2-day-old child without compounding it. We all know that most of the times, the best medication for pulmonary hypertension in pediatric patients is sildenafil, the Viagra that we know. But you see, some patients, like pediatric patients, 5 days old, 10 days old, of sildenafil daily. But Viagra or other brands that we have in the market, you can only see 50 milligrams or 100 milligrams. There's no way you can meet this patient's drug therapy needs without compounding sildenafil to be able to get the required dosage form in the required strength for you to be able to do this. Nifedipine is also one of the drugs we compound most of the times. Hydroxyurea is frequently used in pediatric patients that have sickle cell. You see, sickle cell patients, they take hydroxyurea. Most of the time, they take it for years. And you can only get 100 milligrams, 250 milligrams, and 500 milligrams. And it's in capsule form. Most of the times you see patients, pediatric patients with 70 milligrams, 150, 170, depending on the weight of the child. The only way you can meet this patient's need of hydroxyurea is to compound it using appropriate vehicle and appropriate containers. When it comes to paracetamol, you see that most companies do paracetamol syrup, some do paracetamol elixir, and most of the pediatric patients in the world, you discover that they don't need the syrup, they don't need the sugar in the syrup, they don't need the alcohol in the elixir. So most of the patients in pediatric ward that require paracetamol, you discover that you cannot administer syrup and you cannot administer elixir. And the only way to deliver paracetamol to these babies without administering syrup or administering sugar or administering alcohol is to compound the paracetamol. Furosemide is also one of the drugs we compound. Ciprofloxacin for pediatric patients is also one of the drugs we compound. The pharmacist clinician must be able to take responsibility for the drug needs of the patient, and being able to get exactly what the patient needs and administer same is paramount for you to render an effective and comprehensive pharmaceutical care. Digoxin is one of the drugs that pediatric patients need. Most of the times, 0.04 milligrams per kilogram body weight of the baby is used to calculate the total digitalizing dose of the baby, of the patient. And half of that total digitalizing dose is used as loading dose, while the 50% of the digitalizing dose is used as maintenance dose. Now, looking at these doses, you see that one tablet of digoxin is 0.25 milligrams. And most of the times, you see, after the calculations, you see 0.01, 0.05, 0.1 milligrams. And there's no way you can cut that tablet to get that dose for that baby. The only way out is for you to compound it using appropriate vehicle and appropriate containers for packing. Most of the times, if you leave it for people who are not well trained, they do something that is not correct. For instance, this digoxin, if you use vitamin C or any other vehicle that is acidic, there will be hydrolysis. And what you're going to deliver to the baby will not be digoxin anymore. Phenobarbital is one of the drugs we compound most of the times. We also do chlorohydrate. You discover that in pediatric ward, most of the times, the babies will not be able to stay still for some procedures to be carried out on them. So depending on the weight of the child, the physician will calculate the dose of chlorohydrate that will be used in sedating the baby for the baby to stay still for the procedure to be done. So we compound the chlorohydrate based on the baby's weight, based on the procedure, and we deliver same to the patient for the procedure to be able to be done successfully. Morphine is one of the drugs we compound, most of the times not for the pediatric patients, but for adults. You see, in oncology, most of the cancer patients, they will require the use of morphine. We compound morphine based on the prescription. And if it's a cancer patient that we need to be taking this drug for a long time, we can put bronopol, which is a preservative, to be able to allow the patient to go with like up to 3 months dose and come back afterwards for refill. Trihexyphenidyl, that's the one we call Attain popularly, is one of the drugs we compound. In this case, most of the times the patient can take tablets. The patient will be able to take tablets, but the dosage will not allow you to get the exact dose that the patient needs. So we have to compound it into oral suspension to be able to administer the exact dose that the patient will need. Lugol solution for thyroid problems is also what we compound. Salicylic acid ointment is also what we compound. We compound salicylic acid in different strengths to meet different and varying patient needs. Hypertonic sterile solution is what we have attempted, but we're trying to get glove box, we're trying to get a clean bench, that's sterile clean bench, which is yet to be delivered. When we get that, we'll continue, but for now, we have put that on hold so that we'll be able to get the best out of what we're doing. Clonazepam is just 2 milligram tablet, and most of the time you see babies requiring 0.5 milligrams, 1 milligram, and all that. So we need to compound. Acetic acid solution, most of the times 5%, sometimes 3%. It is used in irrigation of the bladder. Most of the patients that will have catheter on for a long time, with this acetic acid solution used in irrigating the bladder, it will help to prevent bacterial infections and buildup of calcium. And we compound it depending on what the patient needs. Methylene blue is also what we compound. We compound methylene blue for surgeons. You know, they use it as a staining agent to differentiate between tissues during surgeries, so that they'll be able to identify different organs, different tissues, and know where to cut and not where not to cut. It's also an antiseptic, quite all right, but most of the times that they use it to stain the organs during surgery. We compound this depending on what they want to use it for, and we deliver same to the patients for use. So most of these drugs will compound frequently, and will deliver to the patients. This completes the cycle of the responsibilities of the pharmacist. And if you look at the pharmaceutical care philosophy, if the pharmacist is not able to deliver or meet the drug needs of the patient, no one can say that pharmaceutical care has been effective, because that's the major thing that the pharmacist should do as pharmacist responsibility. Okay, let me take a case study. The first one is a patient named ABC. It's a 6 weeks old baby. On presentation in the hospital, the temperature is 36.8 degrees Celsius. The pulse is 180 beats per minute, and the respiratory rate is 32. The weight of the child is 4.6 kg. The child is having right ear purulent discharge, has no fever, no swelling, no tenderness, no tenderness on touching the preauricular area, and no irritability. On examination, the child is anecteric and afebrile. The ear swab was taken and MCS done. The result came out and it showed a mixed bacterial growth of E. coli and Pseudomonas aeruginosa, sensitive to ciprofloxacin. Now, diagnosis is suppurative otitis media, and the physicians prescribed suspension ciprofloxacin 47 milligrams BD times 1 week. Now, the goal of the pharmacist rendering pharmaceutical care is to ensure otitis media resolves completely. The care plan is to formulate a suspension of 47 milligrams per 5 ml ciprofloxacin using distilled water as vehicle. Dispense fresh 25 ml every 48 hours. Monitor and follow up the child. And that is what was done, and a tremendous and successful result was obtained. Case study 2. Patient XYZ, age 73 years, sex female, social history is a retired professor, diagnosis is Parkinsonism. The prescription this lady had was trihexyphenidyl, that's Attain, 1 milligram start, then 2 milligrams daily times 2 days, 3 milligrams daily times 4 days, and then 4 milligrams daily till review. Cinemed 2500, 1 tablet twice daily till review. TAPS Biopentin, 1 tab daily till review. TAPS Nirivite Fort, 1 tab daily till review. TAPS Atrotech 75 milligrams, 1 tablet twice daily times 5 days. Now, looking at this patient's drug need, apart from the drug-drug interactions between Cinemet and trihexyphenidyl, The only way to accurately administer trihexyphenidyl to prevent drug-related problems is through compounding. Because we can see that trihexyphenidyl, if given at doses higher than what was prescribed, will inhibit the efficacy of Sinemet, which is the major drug for Parkinsonism that is being treated. So the dose of trihexyphenidyl must be kept the way it is: 1 milligram start, 2 milligrams daily, 2 milligrams daily for 2 days, 3 milligrams daily for 4 days, and 4 milligrams daily till review. So the pharmacist must compound. 5 milligrams tablets of trihexyphenidyl was then reconstituted into oral suspension using distilled water at 2 days intervals and dispensed to the patient as appropriate. In all cases, however, accurate calculations, appropriate vehicle and dispensing bottles, as well as standard compounding procedure must be ensured. Like most of the countries, including Nigeria, nobody inspects or approves, gives NAFDAC number to compounded medicines. It's only the person that compounded it knows whether what he did is accurate or not. That is why training and retraining, being cautious and being experienced must be brought into bear to ensure that compounded medications are done well in a hygienic manner and in an accurate doses that can deliver exactly what the patient needs without causing any harm. Now, advantages of various dosage forms. The capsules, you can make your compounds into capsules to avoid unwanted dyes and fillers. Oral liquids, you convert one dosage, especially tablets or capsules, into liquid forms, especially for patients who cannot swallow pills, like pediatric patients or geriatric patients. Then you can also do it to avoid ingredients such as alcohols and sugars, like in paracetamol suspension and paracetamol elixir. You can also do it to increase patients' compliance, like putting flavors or improving the tastes, like in quinine or ciprofloxacin that are very bitter. Transdermal gel, you can do this to deliver drugs directly into the bloodstream through the skin to avoid issues. Suppositories or enema, rectal or vaginal, excellent solutions for patients experiencing nausea and vomiting. Topical compounds as a whole, they have benefits of increasing compliance in patients avoiding oral administration, avoiding gastrointestinal effects, increased effectiveness due to direct application, and easy self-administration in as needed doses. In summary, a well-equipped compounding unit is a basic requirement for effective pharmaceutical care. This is not limited to hospital settings alone. Community pharmacies are also encouraged to set up standard compounding units in the premises to ensure optimal pharmaceutical care. I keep wondering, for instance, this baby that has ciprofloxacin, 47 milligrams BD for 1 week, assuming the parents carries the prescription to a community pharmacy, probably they feel they have a pharmacy beside their house and they don't want to get these drugs in the hospital where it was prescribed. And they get to the community pharmacy and tenders this prescription. I wonder what the pharmacist there will say, whether they will say it does not exist or that they don't have it. And if these patients are kept out from community pharmacies, not attended to, they will eventually get into the wrong hands. By the time they get to a quack, to a chemist, you discover that these people will mix something that looks like a compounded medications and deliver to them. They will go home, deliver it, administer it to their babies, and get the baby harmed in the process. That is why the pharmacist must take responsibility, make sure the right thing is done, get compounding room in all pharmacy, in all community pharmacies, in all hospital pharmacies, so that anytime there's need for compounding, that should be done and done appropriately to meet the patient's drug needs. And that will conclude pharmaceutical care process. If not done, nothing is done, somebody else who is not qualified will do it and do it wrongly, tarnishing the image of the pharmacy, image of the profession, and that will not be good enough. Then, considering the intricate technicalities involved in drug compounding, it is therefore imperative to include, highlight, and emphasize drug compounding as part of clinical pharmacy specialist training. Because we see that most of the times, you see pharmacist clinicians who have achieved a certain level in the profession, they keep insisting that compounding is not meant for pharmacy, is not meant for pharmacists who are clinicians. But the truth of the matter is that the clinical pharmacist is supposed to do the compounding, is supposed to evaluate the patient, understand what the needs of the patient is, compound the drug to meet that patient's need. Do it in a professional manner that the patient will benefit from and deliver same. Monitor the patient and ensure that the outcome is positive as expected. For you to set up a compounding unit in your hospital, in your community pharmacy, there's some equipment you must get. Mortar and pestle is one of the basic ones, measuring cylinders, very important. These are not expensive. That's something you can get easily. Weighing balances. You have to get a good weighing balance. Like we have this type of balances, about 6 of them that can weigh different ranges. You need to get weight balance so that you're able to get the accurate weights. You need to make distilled water. You also need to make distilled water on your own. You need to make distilled water on your own. If you buy distilled water in a container from anywhere, you cannot be sure that that distilled water is clean enough. So you need to install a distillation unit, even if it is one, so that you'll be able to make your own distilled water. Ensure the water you use to compound drugs for your patients is good enough, clean enough, and not contaminated. Capsule making machine, you can get this if you can. Ointment milling machine, you can also get this. We don't use this, we use slab. We use ointment slab, just like a wall tile, which we use in milling our ointments. And the patients are benefiting from it despite not using the machine. Suppository mold is also very important in case you want to make suppository. We have a hood. We have a hood that's laminar flow hood. We have this, and mostly we use that for compounding oncology medications. We're also looking for a glove box, sterile glove box, so that we'll be able to be doing sterile compounding. That's compounding IV infusions, so that we'll be able to meet that needs as well. Thank you very much for listening.
Okay, thank you very much, Dr. Chikeze, for that wonderful presentation. Thank you very much. Okay, immediately we'll proceed to the question and answer, the comments aspect of this presentation. So now, so please, if you know you have any question, okay? So we'll take the questions right away. Dr. Timipre, she has a question to ask, so you can go ahead and ask your question.
Yeah, thank you so much, Dr. Chikeze Okuzileze. Thank you for this wonderful presentation. It was very interesting. Yes, compounding is really one aspect in pharmacy that we know is very, very important, and how will I put it? Very peculiar to only the pharmacists. I think that's the only part that doctors cannot really drag with us. physicians cannot drag that part with us. They always come to us when it comes to this. So, but I just have few questions. You know, when you were talking about one of the advantages, you did mention that you know, no need to add preservatives, dyes, sweeteners. But I do know that there are some facilities that still add sweeteners. They prepare simple syrups, simple sugar syrups. They do to add some you know, sweeteners. Like you mentioned, some frequently compounded medicines. Quinine too was one of them. You know, quinine is very, the taste is not palatable at all. And it is always recommended sometimes children within 5 to 10 days when there is issue. So I have seen where some people had sweetener. So although you have explained that it like the paracetamol that you explained, there could be some situation where the person taking it may not need sugar, may not need alcohol, and so you just have to take from the direct tablet and then compound. But in these cases where people add, what do you think? Do you suggest? Do you really recommend that they should add it? Then also, I also want to find out, you in your facility, do you insist on only, because I noticed that your first case, the case study 1, when you were talking about the ciprofloxacin 47 milligram for a child of 6 weeks, you mentioned that that you dispense 25 ml only for every 48 hours. Why don't you just do 7 days, 1 week straight? Do you think it will go bad without the preservative? So thank you so much for your presentation.
Okay, thank you very much. Okay, let me start from the last one. From the case study 1, we dispense 25 meals every 48 hours. That's every 2 days, to cater for 4 doses that they will give the child for 2 days. Then the 5 meals is the average that we're going to retrieve and issue a fresh one. I had the research and training unit, and one of the researches we have done in the past years is to evaluate the stability of compounded medications in the hospital. And we discovered that it's only captopril that still had the activity of up to 90% after 7 days. The rest, furosemide, after 24 hours, gets to about 15% activity. The rest are less than 90% after 3 days. So we now decided to stick to 2 days instead of extending it to 3 days. The 3 days will be in case if the patient cannot come, assuming it's an outpatient, if he cannot come after 2 days and is able to take it for the 3rd day, we can still allow that. But we dispense for 2 days alone for the drug to still be effective as needed. So that is why we dispense only for 2 days. We have the research, we have the data, and we insist that we dispense only 2 days requirement to be able to be sure that what we're dispensing is still effective. Then coming to some centers adding sweeteners and all that, preservatives and dyes. We make simple syrup, 66.7% sucrose in water. We do it. We use it to reconstitute quinine. Ciprofloxacin is very bitter. As I said, it's very bitter.
Yes.
But most of the times, we don't add flavor, we don't add sweetener, especially if it's a neonate, like this case that is 6 weeks. That baby will not know that that drug is bitter. The drug will be delivered. It is better given without sugar or without alcohol. But if it's quinine and it's a child that is up to 2 years, if you don't sweeten it, the child will not take that drug again. Anytime you see you coming with the drug, you run away or you start crying. So we use simple syrup. But we also know that most of the times once you administer any of these drugs in a sugar medium to a child, the efficacy is diminished. So it's better. Most of the time, what we do is we use vitamin C syrup, and the water and distilled water 50% to formulate the quinine, so that the consistency will still be there, the taste will be, the bitterness will be masked a little. At the same time, the drug will still be effective. Again, for quinine, we dispense 2 days requirement. Okay. We dispense 2 days requirement. Then adding a preservative, like I said, for morphine, we use bronopor. We use bronopor to formulate morphine. If the patient is a cancer patient that will take it for a long time, if it's maybe post-operative surgery pain management, that the patient will just take like a week, we don't add preservative at all. We just use distilled water. But if it's a cancer patient that will take it for a long time, like up to, in fact, sometimes up to a year, we can dispense up to 3 months requirement. We add bronopor so that the medication will be preserved. And then we teach the patient how to preserve the drug at home. And then after 3 months, we come back for refill. Thank you very much.
Thank you, sir.
Okay, thank you for that interesting answer. Okay, we have some Dr. Madu. He has a question or comments to ask. So please, you can unmute. So you can unmute yourself.
All right. Good evening, everyone. I believe you can hear me, please.
Loud and clear.
Yes,
okay.
All right. God bless you. God bless Cross River Sipan. We
Amen.
Thank the presenter for once again refreshing our brains. But please, mine is a kind of a clarification. When I saw this topic, I asked the same question. I looked at the topic, it says medicinal drug compounding as a component of pharmaceutical care. So as experts, and sometimes even as fellows, or some of us, we say we are consultants. So sometimes the younger ones or any other person may come to us and ask questions. Members of the education committee, we are trying to answer this question. But I said, no, let me just wait for the presenter so that I can learn more. So my dearest presenter, please, it's just a kind of clarification. I know that before now, actually when I was in school, we did not do anything called pharmaceutical care. When I was in school in my first, in my B.Pharm degree, we never had, or we never see anything called pharmaceutical care in any of our books. It was while I was doing Pharm B in Uniben that we learned about pharmaceutical care. And I know that pharmaceutical care started in 1990 as defined by Hepler and Strange in 1990. But before then, I know that medicinal drug compounding has been in existence. I know that all these formulations that you're talking about this night, they do exist, and pharmacists do these things. Pharmacists can prepare drugs that are not available as standard preparations. They can prepare them in smaller quantities, either for pediatric dosage or special formulations like that. So what I want to say is that I also learned that clinical pharmacy gave rise to pharmaceutical care. Pharmaceutical care gave rise to medication therapy management. I'm still looking at pharmaceutical care as provision of drug therapy and not provision of drugs, but provision of drug therapy. I may want to know the difference between compounding before the advent of pharmaceutical care and compounding in the era of pharmaceutical care, and compounding being a strategic component of pharmaceutical care. Just like I said, for clarification purposes, so that wherever we find ourselves anytime, we can convincingly convince persons that may want to hear from us. Again, I know, or I may want to know, compounding, can it be done at the patient bedside, or the pharmacist has to go to the compounding room to do it? Because why I really want to know about these things is that someone is saying that compounding is pharmaceutical service, and compounding and pharmaceutical service is different from pharmaceutical care. Pharmacies offer both pharmaceutical services and pharmaceutical care. Pharmaceutical care is supposed to be under pharmaceutical services. Sorry, I know as maybe one of the leaders in FIPAN, this kind of question may arise tomorrow, especially from younger ones. I believe my question is understood.
Yes, it's understood. Well understood.
God bless you very much, Mr. Presenter and Cross River FIPAN.
Yes.
Thank you.
Thank you, my chairman. Okay, let me start from the last question. Can compounding be done at the patient's bedside? My answer is no. My answer is no. I try to include the references, although it didn't show the essentials of pharmaceutical care by Azuka Opara. It was spelled out there. For you to render effective and comprehensive pharmaceutical care in your facility, you must have a designated compounding area. In UCH, we have compounding room. Then we have another mini compounding room, which is a designated room that is in the ward. So if you have a need to compound any medication, you move out from the ward and go to the mini compounding room. If the facility you need is not there, you go to the main compounding room. So compounding cannot be done at the patient's bedside. Then moving to the first question. Compounding has been there when pharmacy was a diploma program. Clinical pharmacy came around 1985 when Professor Oluko Ransom Kuti and the deans of pharmacy schools went to US to borrow clinical pharmacy. Now, when you look at clinical pharmacy, you look at clinical medicine, you look at clinical nursing, because I believe those are the three professionals that you see in the world working together to attend to a patient to ensure that patient is taken care of. Clinical medicine is about taking care of an individual patient, examination, diagnosis, and prescription. Clinical nursing, caring for the patient, individual patient in the ward. Clinical pharmacy is rendering pharmaceutical services to a named patient directly. Now, when it comes to pharmaceutical care, because pharmaceutical care is an advancement of clinical pharmacy. Now, taking care of an individual patient, the traditional roles of the pharmacist is still there. Now, when you look at the philosophy of pharmaceutical care, pharmacist responsibility is still there. Now, when you look at the definition of the European Pharmaceutical Care Network, they said contribution of the pharmacist in ensuring that the drug therapy of the patient is taken care of for a definite outcome to be ensured. Now, somebody can say that the pharmacist's responsibility is providing drug therapy and not providing drugs. I don't think I agree with that. The pharmacist's responsibility is, number one, collaborating with the physicians to ensure a plan is designed. For instance, this patient is prescribed ciprofloxacin. This ciprofloxacin is given at 10 milligrams per kg per dose in twice a day, BD. And the weight, from the weight you calculate the dose, and it's 47 milligrams. If the pharmacist cannot provide 47 milligrams per dose of ciprofloxacin, I don't think that pharmacist is rendering pharmaceutical care. If the pharmacist should delegate this responsibility to a technician, the technician can bungle the process and render the whole process invalid. So even the definition given by most of the schools of thought it is well spelled out that the pharmacist's responsibility is his ability to meet the drug-related needs of the patient, then being able to monitor and follow up to ensure that the proper thing is done until a definite outcome is achieved. So based on this, I believe, and I strongly believe and agree with the authorities who have stated it earlier, that compounding, drug compounding is a component of pharmaceutical care. And if the pharmacist, being a clinician, even if he's a consultant pharmacist, ability to meet the drug needs of the patient is one of the components of pharmaceutical care. I agree with those authorities, and I believe that is true and correct. Thank you very much.
All right. Yes, thank you, Mr. Presenter. God bless you. You really answered my question. I think 100% excellent. Yes, and you made references. I know as scientists, whenever we make claims, we back it up, and you have just done that. At least tomorrow, when I'm talking about that, I can quote Azuka Okpara's writing. I know it was reviewed and approved. So God bless you. Thank you so much.
Okay, thank you, Mr. Presenter, Dr. Chikeze, for that. You actually dealt with the question. Okay, Dr. Bello, let's take your question, Dr. Pharmacist Ibrahim Bello.
Thank you, Dr. Agari. And I want to thank our speaker for that excellent and well-designed presentation. We have these two questions for you. Hello, can you hear me? Yeah.
Yes, I can hear you very well.
Okay, my first question is on compounding of drugs that are designed for a certain release, like Stoke, and drugs that are coated because of our taste. So what do you have to say about the ethical issue on these ones? Drugs that are coated to ensure a certain release, or coated to mask their taste, and we cross them. Is there any ethical issue? That's number one. Number two is that all the drugs have information on them, whether they should be compounded or not in our official books. Do we bother to check them before we go ahead and compound? That's my second question. And the third is on the quality assurance. What do we put in place in our compounding unit to ensure that the drugs we are issuing out are safe for consumption? That's the last one. Thank you so much.
Okay, thank you very much. Let me start from the first question. Drugs that are formulated as extended drug release.
Yes.
Yes. Those ones, you cannot compound them.
Okay.
You can't compound them. We have so many medications that have extended release and the plain tablets. So if there's any need to compound them, you must get the plain tablets. Take, for instance, even, and I talked about coated ones, even ciprofloxacin we're talking about, this Ciprotab, if you can't compound Ciprotab, it is coated. So we look for tablets, a brand that is not coated, or maybe the one that has a film coat that we can easily compound. So extended release tablet is a no, coated ones is also a no. But for instance, quinine is coated, but it's sugar coated. So we compound quinine, and there's no issue with that. The coating is just, the sugar coating is just because of the taste. And when we compound it, definitely you have to mask the taste for the child to be able to take it. Then the next, any ethical issues? Yes, there are a lot of ethical issues. If it's extended release, it's scientifically wrong for you to, because if you know the technology behind extended release tablets, you know that compounding them is a no. Now, going to information on whether a particular drug can be compounded or not, we do that. Martin, the extra pharmacopoeia is replete with a lot of information on whether a particular drug can be compounded or not, including the vehicles that must not be used. For instance, the digoxin can never be, you can never use vitamin C to reconstruct that. They're always spelled out. We use for BPC, British Pharmaceutical Codex, some of the information that you need are also there. So we check information on whether a particular drug can be compounded. If need be, you get the pure sample of that drug and then build up we are trying to use compounding and reconstitution interchangeably, but technically they're not the same. They don't mean the same. So what we're discussing is compounding, but most of the times what we do is reconstitution. That's changing from one dosage form to the other. So if a tablet cannot be crushed and is well spelled out, you don't need to crush it. If you want to compound that medication, you need to get a pure sample. And sometimes that's what we do. We get the pure sample and build up a preparation from the scratch, and then ensure that we meet the needs of our patient. Now, about quality assurance. I like the terminology you used, because quality control is different from quality assurance. What we do basically is quality assurance. We ensure that the calculations are accurate. We ensure that the environment is clean enough, because we have laminar flow hood. If need be, we do it inside the laminar flow hood. If it requires distilled water, we make sure we use distilled water that we distilled ourselves. So we make sure that the ingredients are pure and sterile, and pure and clean. We make sure the process is pure and clean, so that the product we are going to get is also clean enough for consumption. Now, when you talk about quality control, we do quality control once in a while. Like the one I mentioned, we took about 12 samples of frequently ability test medium. You discover that the degradation is very rapid, and after 3 to 7 days, the activity gets below 90%. So we decided that we cannot dispense more than 2 days requirements. So we do a lot about quality assurance, ensuring that each step is validated, verified, and we ensure that whatever we are doing is accurate based on the reference requirements, the reference recommendations, that's recommendations from the reference books, and then the standard processes must be insisted. We have an SOP. Anybody that should compound. That's why in other countries, like in the US, we know that not all the pharmacists compound medications. You must get a license for compounding before you do that. Why? Because FDA doesn't need to come and give license to the product you are making. They will give you as a person license to compound, to be sure that you know what you are doing. So the same thing we do. I run the compounding room in UCTH. Before you compound medications, you get trained. Before interns should touch anything or do any compounding, they get trained. Because by the time you do the transition, nobody will come and do quality control on the product that you have compounded. So it's for you to know what to do and then follow the process, which is quality assurance. That's exactly what we do. Thank you very much.
Thank you for that one. It's a very
Wow,
good one.
wow, such a sounding response. Okay, Dr. Chikeze, thank you for that. Okay, Pharmacist Eugene has a question to ask, so please unmute him so we can. Pharmacist Eugene.
Good evening.
Yeah, good
Thank
evening.
you, the presenter, Dr. Chikeze Okwesilieze, and the participants. I want to associate myself with the observation of our chairman. We know that pharmaceutical care is patient-centered, and compounding and dispensing are product-oriented. Now, I think, is it not better we train our technicians and do compounding under supervision and focus on more important aspects of pharmaceutical care, because pharmaceutical care is a bit complex. If we start focusing on the product aspect of pharmacy, it's like we are retrogressing. There are many innovative developments in pharmacy, digital health, informatics, so many things. I'm not trying to underrate compounding, but I'm saying that if we are emphasizing compounding, dispensing. Even the proponent of pharmaceutical care are saying that the technicians should do most of these things under observation, under the supervision of the pharmacist. So what I'm saying is that, is it not better we train our technicians very well to do compounding under supervision, instead of a pharmacist being involved? And it's better for us to do more important aspect, because we don't have the time. Sometimes patient, you cannot even have time to monitor well and do most of the important aspects of the pharmaceutical care, because pharmaceutical care is patient-oriented, not product-oriented. It's a paradigm shift. So I want the presenter to react to my observation and
yes,
question.
thank you very much. Thank you very much. I purposely got interested in this topic because of the way and manner most of our senior colleagues are championing this line of thought. Pharmaceutical care is patient and outcome oriented. Is patient and outcome oriented. Now, when you look at medicinal drug compounding is patient oriented. You may need to find out that. You may need to look at that. Read pharmacy books, and you agree with me. Medicinal drug compounding is patient-oriented. If you compound drug for an unknown patient, it is not medicinal drug compounding. You are doing drug production. Now, drug, like in our SOP, there must be a name, there must be a need for the compounding. Maybe because there's no commercially available product that can meet that patient's need, and so on and so forth, before you can go into compounding. So medicinal being patient-oriented and outcome-oriented. Now, what I normally say to our physicians, when I talk to them either on TV or radio, or when I talk to them in seminars or wherever, I tell them that your professorship, you have examined the patient world, and you have examined the patient, you have written a prescription. For instance, you have written a prescription of XYZ drugs, and what was brought is a fake drug administered to the patient. All those things you have done is useless. The main thrust of the pharmacist's responsibility is to be able to get
network is
Dog.
yes, network.
Network is allowing us to listen to dog.
Please unmute him. Unmute.
Can you hear me now?
Yes, we can hear you.
Hello?
We can
Hello,
hear
can
you.
hear me?
Yes,
Loud
we
and
can
Can you hear me
clear.
now? Okay, thank you. So still on the last question.
Yes.
Still on the last question. I still believe that when you look at the philosophy of pharmaceutical care, which is the pharmacist's responsibility to meet specific need, the specific drug need of a patient, that the most important aspect of that pharmacist's responsibility is to be able to get the exact medication that can meet that patient's specific drug need. And that is the main thrust. If you cannot do that, whether you are busy trying to do whatever, all that you are going to do will be a waste, because what the patient is taking is wrong. And you cannot deliver that patient, you cannot get that patient's need, the outcome that you are trying to ensure will be disastrous. So, but having said that, like for instance, I'm an assistant director, I run the compounding unit. I'm not the one that do everything in there. I have people, I have pharmacy technicians, I have pharmacy interns, I have chief pharmacists, I have principal pharmacist, pharmacist one. Everybody is involved. But the responsibility that the pharmacist is taking, if I go to the ward and I have a patient I'm rendering pharmaceutical care, I am the one that will take responsibility of that patient's drugs need. So since the pharmacist must take responsibility, who is going to take that responsibility? I am the one, the team leader. The same way, the consultant physician is the one that is taking responsibility for the treatment of that patient. The pharmacist who is leading the team is the one that will take responsibility. It does not necessarily mean that I'm the one that will do the compounding, but I am the one that must ensure the right thing is done, ensure that it's done properly, ensure that it's done well and delivered at the appropriate time, and ensure that those drugs are administered properly, monitor the patient and follow up, and ensure that the outcome which I desired is what I'm getting. Otherwise, whatever I have done as pharmaceutical care rendering or whatever I've done as clinical pharmacy, I don't know if I answered your question.
Okay, yes, okay, I believe
yes, to some extent.
Yes. So we can actually get from what Dr. Chikeze is saying, in the midst of all our pharmaceutical care practices, if the right drug doesn't get to the patients, everything we've done is actually futile. If the right drug doesn't get to the patient, you do everything, you draw a plan and everything, and the patient ends up taking the right drug, everything it's actually it's hitting against the brick. So the goal, the medicinal compounding enabled us to ensure that the right drug gets to the patient in the right dose, also the right drug in the right dose and the right form gets to the patient.
Yes,
okay.
Like I don't know whether network allowed me to be heard when I said that when the philosophy said that the pharmacist should render pharmaceutical care and take responsibility. Now, the pharmacist is taking responsibility for providing the right drug to that patient at the appropriate dosage form, appropriate strength. It does not necessarily mean that you are the one that will do the compounding.
Yes, but responsibility.
The compounding can be done by people who are working with you, but it's you that will take responsibility. So it's you that must make sure that everything is done appropriately and delivered as appropriate.
All right, thank you for that. Okay, our time is fast spent. We'll just take some few questions. Please, let's be very brief with our questions so we can see as much as we can take. Subsequent questions can be following questions can be sent to the platform where they will be answered later on. Okay, Peter, Pharmacist Peter Afonsos, please, you can ask your question.
Hello, good evening, all.
Good evening.
Yeah, good evening.
Okay, this is Dr. Alfonso Peter on the line.
Okay.
Yeah.
So in line with what the presenter has said, I'll give a brief addition to my personal experience with pharmaceutical care as regards compounding. Now, it's actually a delicate area. It's not too straight like it looks. But then if you look at special population, for what he has said, compounding is for special population. The elderly are part of the special population, and the pediatric patients, he even talked about 1 month, 2 months old. Now, that actually should inform us or get us closer to the patient. The last time I did compounding in the hospital setting was for HIV patients, maternal. One of the things we ensured then was, one, to get the accurate weight of the patient. I discovered in that system that the nurses were not giving us ideal weights of the patient. Subsequently, we started doing the weighing of these pediatric patients in the pharmacy. We got a weighing scale where probably we could weigh the mother and the child and now weigh the mother alone and do subtractions. In that way, we're able to actually make sure we're getting the right dose for this patient. At times, whatever calculation is done by the nurses or whoever, they might actually make some mistakes. They might weigh patient A as patient B. And if what we are going to do is just to compound the drug according to prescription and dictates, we might actually have some issues. So compounding should actually avail us the opportunity to verify the identity of the patients who are compounding this drug for. It should actually make us engage the patient a little more than just compounding for some people we don't know. And in addition, of course, we need to step further, like he had said, to see these patients in the ward, look at the effects of this medication on these patients, if they actually tally or they agree with the principles of our pharmaceutical care. And by so doing, we will be rendering patient monitoring advice and know at what point, to take on whatever we do. Again, remember, what probably we compound to the patient may not be the only drug the patient is taking. It's possible the patient may be taking some other medications, probably like some antibiotic or so, that we are not aware of. So by mere compounding the medications, we need to step further to see what other drug these patients take. Let compounding take us closer to the patient, engage us with the patient so that we can actually, employ our clinical services. So I think compounding should afford us a little closeness to the patient. Even when ordinarily we are not close to the patient, we shouldn't just stop at what we have compounded. That's my view and take. Thank you.
Okay, thank you very much. Okay, thanks for your contribution. Okay, Dr. Adro, please, you can unmute yourself. Dr. Adro.
Thank you very much, Mr. Agari, for this opportunity. Well, at first I want to thank the presenter for a wonderful presentation. Wonderful, excellent presentation. On my end, the issue is kind of complex. Now, compounding in the community practice setting will have a different approach compared to the hospital setting. Now, for the community setting, you are all and all. So you have to provide that service for all patients that come your way. However, for the hospital setting, seems to be a different ball game. Like Dr. Eugene mentioned, in my center, we have a pharmacist who supervises, watches the goes through the calculations and the write up by the technicians, and the technician does the actual work, freeing up time for the pharmacist to do other things. However, we have a pharmacist that does the checks and all of that. So for me, in the hospital setting, because we have loads of clinical work to handle, the question of specialization now comes in. I think the suggested approach I would rather recommend is we have a pharmacist who's in charge of compounding, because for each of these medications, you need to determine the right solvent, determine the stability and all of that. Now, having the pharmacist who is monitoring the patient in there to still come and be bothered about that, it's really, really, really bogus and a huge responsibility. Like the presenter was trying to make the point that the patient you are monitoring, you have to ensure that the appropriate dose of the drug is made available. Yes, you are monitoring the patient in the ward, and the patient requires, the pediatric patient that requires furosemide or spironolactone suspension. I think that responsibility should now shift to the pharmacist who is in charge of compounding. Now, we should have confidence. You, the clinical pharmacist who is working with the patient in the ward, should be confident that at that point where you've determined that the patient requires this dose of spironolactone suspension, you now call in your compounding pharmacist who now supervises the product. When the product comes, you should be able to believe that he or she has done what the patient needs. Just like we want the physician to have confidence in our inputs at the patient bedside. That is on the one hand. On the second hand, I used to have this perception of compounding having to do with just converting the tablets to the suspension and all of that. However, as part of the Hospital for Humanity team at the IBOM Specialist Hospital, where open heart surgery was done free open heart surgery was done, a different perspective opened up. We had this laminar flow hood. Interestingly, the US team that came know all injectables for the pediatrics, all medications are prepared by the pharmacists per dose. So all the IV medications we had to prepare in the mobile flow hood. We drew, even though the ampoule says 1 milligram per mil, no child is given concentrated ampoules. You must serial dilute. And we prepare all of that and we hand over just the syringe without the needle to the nurse at that point of administration. So you were on your feet 24/7. If you're on call, God help you. You are by that patient bedside 24/7. Whenever any medication is needed, you have to go withdraw in the flow hood, prepare, serial dilute. You have an SOP for each medication, the dose, the concentration that must get to the child. And that was what we did all through. Then I realized that it was not just converting tablets to suspension. Even injectables are not administered as they are in the vials. No matter how, even though the child needs 1 milligram and it is 1 milligram per mil in the ampoule, no child receives that. It has to be 1 milligram in 10 mils. And using the IV set, it is given over a specific time. Unlike our Nigerian system where we just, okay, it's 1 milligram and we push everything. And all of these babies, open heart surgery, 2 days they are discharged home because we are by the patient bedside 24/7, monitoring, giving medications, not at concentrated doses, but diluted doses. So it was going into the system gradually. So compounding is a very wonderful aspect of pharmaceutical care. Let's be true to ourselves. And our approach in the hospital is definitely going to be different from the community setting. Now, a lot of equipments have been shown that we should have. However, we must not have all of this, especially in the community setting, for us to compound. My former intern exposed me in one of the community pharmacies where I also consult. A patient came in requiring spironolactone. A prescription came in for a neonate requiring spironolactone. And lo and behold, the pharmacy did not have a mortar and pestle. He was my former intern, but he's now working in the community pharmacy. He was so ingenious and he said, all he needs, Chief, I can do this. I said, what do you mean you can do it and there's no mortar and pestle? He said, just give me a tea mug and a spoon. And that was how we compounded. So as a community pharmacist, you need to be creative. Even in the hospital setting, you don't need to have everything in place for you to do what you are supposed to do. All we need is creativity. Thank you.
Okay, Dr. Ejo, thank you very much for those assertions. Thank you. Okay, we have more questions, but time is actually fast spent and closing up. Okay, please, if we can make it more brief so we can get all the that was a comment, various assertion. So okay, pharmacists more in 1-4. Okay.
Good evening,
everybody.
I'm glad that I listened to this wonderful presentation.
So I have
a few questions. Earlier, the presenter informed us that they do use vitamin C syrup to compound tablets for the children. And in my center, we used to do that. At a point, we realized that there may be drug interactions with that vitamin C.
Yes.
So we now start to use sherry syrup.
Okay.
So I don't know your experience in using vitamin C to compound. Another question, you mentioned that your center, you people cannot do hypertonic saline. We have the same challenge in my center. So I want to ask, in absence of hypertonic saline, what are we going to do when we have patients that have a hypernatremia, highly hydrated, edematous? What are we going to do in absence of hypertonic saline? Thank you very much.
Yeah, thank you very much, Dr. Murray. Like I said, ability to be able to pick the right chemical to be used for the compounding is very key. I gave an example of digoxin. If you use digoxin, if you use vitamin C for digoxin, you are wasting that drug and you are putting that patient in harm's way. So, but for quinine, I said we use simple syrup. Simple syrup, that's 66.7% sucrose in water. To compound quinine, to compound quinine. We also use vitamin C to compound quinine. And if you look at the marking there, extra pharmacopoeia, it is well stated there. Some people were saying that quinine is a basic drug and vitamin C is acidic, that there will be reaction and interaction, this and that. But it's well stated in Martin there. You can use vitamin C to reconstitute quinine. There is no interaction whatsoever. You can use simple syrup, there's no interaction whatsoever. But like I said, most of the times for pediatric patients, we use distilled water because when you keep out alcohol and keep out sugar, the patient gets better easily. We have done that as a research and it's confirmed. When you keep away sugar and alcohol, the patient benefits better from the drug that you have prepared. So that's my response to that. Coming to hypertonic solution. Hypertonic solution, we have placed order for a glove box or a clean bench. That's a sterile clean bench. We have laminar flow hood already, but we cannot use that to prepare sterile products, sterile preparations. So what we said is that if the preparations we're going to deliver to the patient will not be sterile, then there's no need to do that. So we placed order for that, and once it's delivered, we can make sterile preparations. So what I would say for that is that it is better not to do it than to do something that will not be the best. So delivering a saline solution that is not sterile is not good enough. So it's better not to do it at all. So that's
okay. Thank you very much. Dr. Andrew Benny, you are supposed to, I can't see you anymore. Yes. You're supposed to be the next Dr. Agbeni Andrew. Okay, I can't see you anymore. All right. In the absence of a lot of comments and questions going on the page, as in was dropped there. And but time is fast spent. We've learned a lot. I will just want to make an appeal with Dr. Chikeze, if he can please just as regard compounding, if you can give us a little compilation on some of the drugs that are commonly compounded, and they are suitable vehicle for them. Like now, I know of a pharmacist that have been compounding digoxin with vitamin C. He has been yes, yes, he has been yeah. In fact, almost everything he compounds, he uses vitamin C. So he uses vitamin C. So please, if you can help us with a write-up, and you can send to the Education and Training Committee on suitable vehicles for compounding various medication, that will help, and it will be like it will help. It will help if you can do that for us, since you are a specialist in that area. We will appreciate that.
I'll do that. Okay. One thing I want to add again is I want to thank Dr. Ejiro for his contribution. What he said is exactly what we have started doing in our center in terms of oncology pharmacy. In fact, the way the oncology pharmacy is designed, in fact, the oncology team, whether injectable, whether infusions, be it whatever, the pharmacist will reconstitute and compound everything and hand over to the physician to administer. So for people that still see compounding reconstitution as not being clinical, when you see the setting, I think Dr. Jiro has been able to give me a little support. When you see what is happening, pharmacists compounding and then coming to the ward, to the bedside with the preparations, and then giving the physician to administer while you supervise, and then you take responsibility. Thank you very much.
Okay, thank you. So, closing remark, please. I'll call on our Education and Training Committee Chairman to give us a closing remark, to give a remark and close the meeting for us. Thank you.
Yeah, I just want Dr. Peter, can you mute yourself for? Yeah, I just want to thank you so much, Dr. Chikeze, for this wonderful presentation. I really appreciate it. And we really appreciate, honestly, and we are even looking forward to have you again and again. Yes, and there's something I feel, I know that the school, the postgraduate school, WAPCP, has this as another, as a kind of, specialty in drug production. Is there in drug production is a specialty, because in my facility, the pharmacist heading it has is a fellow in drug production. So it is really in line. So we really appreciate this, your wonderful presentation, and just like we have said, we wish to have you again and again with time. So thank you so much. And the moderator, thank you so much for your wonderful moderating. Thanks so much. We really appreciate it.
Thank you.
Okay, so this will be a goodbye for today. See you same time. Is it same time next our next clinical meeting, and I'll be communicated. Thank you, Rivers State, Cross River State, for this wonderful presentation.
Thank you very much.
So much. We really appreciate it.
Yeah, good night.